All right, so without any further ado, I'm going to go ahead and introduce our speaker while a few people come in so that we make sure we have enough time for him to give his talk. So again, good afternoon, everyone. My name is Juliet Sekandi, and I am an associate professor here at UGA in the Global Health Institute. I coordinate and help to organize the Global Health Seminars, which are a seminar series that we run every month, once a month, every last Thursday. And we run those year-round, meaning fall and spring. So we welcome everyone who has just joined for the first time, but just so you know that we'll have a series of those running every end of the month, and the announcements will be out and circulating probably at the beginning of this month for the next speaker for October and then for November. So we will have at least two more seminars coming up. So look out for the announcements, and we will try and reach out to whoever has signed up with their emails, and maybe through the class ELCs, we try to announce that and use as many channels as we can. So today I would like to introduce our speaker, Dr. John McCracken, who is a professor in the Global Health Institute in the College of Public Health here at the University of Georgia, and he is an environmental epidemiologist, and he focuses on preventing both infectious and chronic diseases by understanding environmental risk factors. So his main research area has been on the health effects of household air pollution due to solid fuel use, which was estimated to cause about 1.6 million premature deaths in 2017. And of course, the number doesn't change that much until we have very effective interventions. But this was more primarily in low and middle income countries. So Dr. McCracken has also had a track record of over 10 years of just expertise in the household air pollution research, and he has worked on large NIH-funded studies in collaboration with UVG in Guatemala, the CDC, and Peru, Rwanda, India. So truly a lot of global collaborations and just really making contributions, great contributions in this area of household air pollution and health effects. So today he's going to tackle a topic that is near and dear to his heart, again, around household air pollution and childhood respiratory illnesses in Guatemala in relation to some of the new research projects that he's been funded to do. Dr. McCracken, you're welcome to take the floor or the mic, I guess.
Yeah, thank you, Dr. Sekandi, and thank you, everybody, for coming. And yeah, I hope we have, I'm not good at this, but I do hope to leave time at the end for discussion and hear your thoughts, because I think this is a great opportunity for me to kind of step back from some research I've been working on for a long time and try to figure out some, as I'll mention, somewhat paradoxical findings that we've had in this area of research. So household air pollution, and I'll focus on respiratory disease. Household air pollution has many other health effects, but I've been mostly focused on respiratory disease. We're going to look at what the epidemiological evidence is, and then sort of what the interventions are. So to start out, where I've spent a lot of my life, actually almost about a third of my life in Guatemala, and a little bit about Guatemala is this situation here that it appears in this study, for example, as the GTM, the country with the highest incidence of childhood pneumonia in the whole world. So that's, you know, I'm sure there's some possible error to that statement, but certainly it's among the highest. So just, you know, that's sort of the backdrop, and we're trying to focus on one risk factor that we think might be contributing, and that's the focus of the talk. But I just wanted to put in the context of where we're doing the research, that in particular the burden is potentially very large, just because there's a high background rate of this disease for some reason that's not completely explained. And of course, it is among the poorest countries in the hemisphere, but yeah, that alone doesn't seem to explain it. So, so household air pollution. This this image from the highlands of Guatemala is, showing a woman doing what she probably would have done 2 or 3 times a day, is to prepare food over an open fire that we call a 3-stone fire. And as you can see, it's a very high exposure situation to smoke. And so the exposure is also very high for infants that are typically carried on the back. And this is common in many cultures around the world, that women and infants are very close together and spend a lot of time, therefore, in the kitchen during early life. So this Latin proverb, actually, that the kitchen kills more than the sword, I think still may be true. But I don't think anyone back then was really thinking about the smoke. They were thinking about eating too much food and also getting food poisoning, I believe. But I think it wasn't until actually the late 20th century that people started to think about this as a health problem, which is surprising. But it took quite a lot to get the attention of the public health field to this towards this problem. So my presentation is following this logic that I wanted to just introduce you to what household air pollution exposure is and how we think about it and how we come up with estimates of the burden of disease globally. And that is all mostly based on epidemiological studies, cohort studies, case control studies, and cross-sectional studies, ecological studies, many forms of evidence. It's also supported by toxicological evidence, and it's also supported by evidence from other sources of air pollution like tobacco smoke and ambient air pollution from traffic that are known to have similar health effects. So altogether, it's thought to be quite strong evidence. But then the next part of the talk is how, when we've tried to do intervention trials, we haven't really found the effects we expected. And so the third part is therefore to discuss some possible explanations for this paradox based on causal identification criteria or basic causal inference in epidemiology, and therefore try to direct future research to address these issues. And that's the fourth part of the talk. So a little bit about exposure assessment, but first to say, in terms of exposure and the epidemiology. So my mentor, Kirk Smith, actually in this book made calculations of estimations of the burden of disease from household air pollution in the 1980s, and this was before any epidemiological studies had been done in these settings. And so these were all based on calculations of just sort of environmental modeling of saying, how much smoke do we think people are breathing in? How much time are they in the kitchen? How much wood are they burning? When you burn wood, how much smoke occurs? So these sort of this is a form of risk assessment that completely borrowed and said, from the evidence of tobacco smoke that says, cigarettes are just biomass and wood is biomass. When you burn the two, the emissions are essentially the same, and argued that, admitting that there could be differences, but arguing that overall they're just pretty similar mixtures of air pollution. So based on very solid evidence of the effects of tobacco extrapolated. So that's what this book was about, and it really was trying to bring attention to the fact that we really need to learn more about this, and we probably need to do something about it. So there he is holding also, this was in the early 2000s, he was the first one to actually make a real-time air pollution monitor that was very small and cheap, and you basically just take the smoke alarm off the ceiling of your house and you attach a data logger to it. And instead of getting a loud noise when the signal goes above a certain level, you actually capture the signal that the smoke detector is detecting, and that is actually, this was the first version, and after that it's actually very common. You can buy them online. There's somewhat more sophisticated, but it's widespread networks around the world now of these kinds of monitors. So he really was a pioneer in environmental health. And so exposure assessment. So I'll talk a little bit about this just for people who aren't in environmental epidemiology, or another branch of epidemiology that focuses a lot on aspects of exposure assessment. I want to just introduce you to a framework and then talk to you about household air pollution in that framework. So when you think about exposure assessment, you really want to first start out with, hypothetically, what exactly it is that people are exposed to that's harmful. So it might seem obvious that, you know, the causal agent, obviously it's the stuff in the air, but when you want to go to measure it, you need to figure out what it is and how to measure it. So it turns out the biomass smoke is, you know, made of thousands of different chemicals, and several of them are known to be toxic. So what exactly do you measure? And another point of conceptualizing the exposure is on a pathway from exposure to disease. Where do we need to be measuring this exposure? Do we just need to measure where it comes out of the stove? Do we need to measure it inside the household? Is it also important outside the household? Or do we actually need to measure it on a person? Do we need to have the monitor personally, attached to the person, so you're getting personal exposure measurements? And you can go further. Do we want to actually measure the air pollution that deposits in their lungs and things like that? And that's so then you need to operationalize this idea, right? And maybe I should add to that, for some people, right, maybe the exposure is not necessarily, maybe it's just using that fuel, or maybe it's cooking that way, and so maybe it's the fuel, maybe it's the stove, or the behaviors, and not so on another level. One could think of exposure in many ways, and I guess just broadly, any intervention that you could do, you could also think of that's an exposure. Either you have that intervention or not that might reduce air pollution. So getting on to number two, to operationalize this, you need to think of a variable. What is the variable going to be? And it has to have a couple components that are key. And one is, what's the representation of dose that you get? And so this can be just dichotomous of you have some or you have none, or it could be quantitative. And for us, if we talk about just, is the exposure just using solid fuels, right? It just could be yes or no, ever versus never. It could be how many days a week, how many years. It could be just like smoking is studied in terms of pack years, for example. And if you want to talk about air pollution, right, the dose representation could be actually the concentration, like a mass per volume of air, for example. And the other key element to this variable, it needs to be defined and to be time specific, right? You need to say, when might the effects occur in relation to when a person was exposed? Like, do our exposures in early life determine acute diseases right away, like pneumonia, or do they actually determine diseases far in the future, in later adulthood, like chronic obstructive pulmonary disease? So we need to sort of think about what we can measure over those different time periods and how, and that's where we consider, what are the data we're going to collect. So I'm going to talk to you about the two main versions of exposure assessment. So hopefully this framework will help you think about them. So the first one is back to just, looking at solid fuel use as an exposure. Like, do you cook with solid fuel or do you not? And it's very simple. And it turns out that sometimes things that are simple are the best, because that question can be easily asked, and it has been asked to millions of people all around the world in the demographic and health surveys and censuses. So there's lots of data on that, and I'll show you some. So here is some recent data on household cooking fuel estimates at a global and country level, and just to show how they classified into just two groups of, is your fuel clean or is it polluting? Basically anything that's solid is polluting, and also the liquid kerosene is quite toxic as well. And then the green are some fuels that we're all more familiar with, particularly LPG and electricity, and those are on the clean side. So we can just dichotomize households, during at any time period which of these they're using, and that's what has been done in this global database that shows the trends over time in the rural and urban populations globally, and how many people use and what proportion of the global population uses polluting fuels. And you can see, if we look at the overall graph, right, back in 1990, when the first epidemiological studies were occurring, right, it was just a little bit over 50%, and we're currently just under 40%. So as a proportion, it's getting better, but if you look at the total of the darker blue area, the number of people exposed is still pretty similar. And of course, you see a strong contrast between the urban and rural, in terms of the proportion, and although the rural population, the proportions coming down as well. So there's good news, and a lot of that's just happening because really nobody wants to use these fuels that are dirty. It's just that they don't have enough money to buy the ones that are clean and that are convenient and all that stuff. Well, I shouldn't say nobody. I should say in general, people would prefer to use cleaner fuels if they could afford to. So a lot of that's just happening because of development. Some of it's happening because of programs that are occurring as well, particularly in some countries. So the same data looked at by region. I think the main thing this shows us is that the problem these days, of course, the countries, Oceania outside of Australia are not a very big population, Papua New Guinea, places like that. But sub-Saharan Africa is a very large population, and we're up sort of, around 80%, or 4 out of 5 families cooking with polluting fuels. So, in a population, again, where also pneumonia in early childhood is a large public health problem. So, and there's not much of a downward trend, just slightly. So a lot of work to do there. If you look at Latin America, for example, there's a lot of improvement, but where I have been working, is Guatemala and southern Mexico, and the northern triangle of Central America is closer to sub-Saharan Africa than the rest of Latin America. So these categorizations often don't really capture, but in the rural areas in Guatemala, the vast majority of people cook with solid fuels. So using this kind of exposure variable, this is essentially how almost all of the epidemiology had been done until about 12 years ago or so. And so this is a meta-analysis of different kinds of studies that I mentioned for the outcome that's been most studied in relation to household air pollution, which is pneumonia. So just to all of this sensitivity analysis within this meta-analysis is all pointing to the fact that these are robust associations, controlling for confounding, using different classifications of clean versus dirty, but they're all categorical based on observations and questionnaires of exposure. None of this is measuring air pollution, but the the bottom line at the top, right, is a relative risk of 1.78 for pneumonia. So if you take the #1 killer of infants in the low and middle income countries and you multiply it by 1.78, that's a very large burden, particularly since, you know, where the same communities where solid fuel use are the same places where there's a very high incidence of pneumonia. So that those kind of converge and produce a large estimated burden of disease. So that's categorical exposure assessment. That's how most of the epidemiology in these settings has been done. And then, so it raises the question, though, that, well, one, you know, what just, you know, is it really, is the dichotomous variable, or does it really have high validity? Does it really explain a lot of the differences in exposure? And what we find is that it's not necessarily the case. You can see this plot, for example, all of the people use solid fuels. Some people have a chimney and some people don't. And you can see that these two distributions are quite distinct. So this is, you know, just one example, that, and they're all other, you know, ventilation, the volume, the amount of cooking, there's a whole bunch of factors that will produce variability. And also sometimes, as I mentioned, this, the different exposure variables, right? How you also need to think about those exposure variables that I mentioned. Where in the pathway of exposure to disease do we want to study this? And sometimes to have more specific associations that allow us to explain a little more the relationships, and might be have a tighter relationship and perhaps less confounded. For example, because, as I mentioned, whether you use solid fuels or not is mostly determined by your socioeconomic status. So it's hard to remove that confounding, or it's hard to be really sure that you can remove that confounding. So you want a variable that captures other sources of variation in exposure that's, let's say, might be more similar, to assume that it's more random. And so that's one of the reasons, you know, that it's important to consider actually measuring exposure and getting for each individual an estimate of their actual exposure. So this distribution plot is showing a range of exposure among people who use solid fuels. Because, you know, if solid fuel use maybe in one place is associated, because of other conditions, is associated with a very high exposure, where in some places, again, maybe they have chimneys, maybe they have large homes, or maybe they cook outside, like in a lot of places, right? The exposure is, so it's really it's not the same exposure. So it's not really a really clear causal question of what's the effect of solid fuel use. Well, we can say it depends, right? It's not just, there's not going to be just one effect. So that's one of the, you know, these are the reasons why we want to measure exposure. And this is a little bit about how you do it. So the first studies that said, okay, Kirk went to India and did the first measurements, let's actually measure this stuff. And so a lot of what happened is they put monitors like while people were cooking in the kitchen. Like the monitors back in those days were very, very clunky and heavy. You wouldn't want to carry it around, certainly not all day. And so people sometimes in studies carried them just while they were cooking. So this was very helpful, but eventually, you know, it was realized that personally, actually putting the monitor on a person was very important. And what exactly are we measuring? And what is the agent? It's a mixture of pollutants. So fine particulate matter, you might have heard of PM 2.5, which is the common pollutant that the EPA regulates, and that, you know, has led to a lot of control of air pollution in the US and other countries, is based on the pollutant PM 2.5, and 2.5 refers to the size of the particulate matter, and it's a size that can deposit deeply in your lungs, which is more likely to be associated with respiratory effects. So it's really important also to measure in complete days, right? Because people don't cook all day. And so you want to kind of get something comparable across locations. You want to see the whole day. So 24 hours or 48 hours. Some people measure for 72 hours, but these monitors, right, they don't just keep going and going, and people won't carry them around every day. So you need to kind of do short-term measures. Another thing is that these monitors, even though they've gotten much better, we still can't put one of these, you can see the size there of the RTI ECM monitor. You can't put that on a newborn baby, right? So if you want to know their exposure, you need to look for a monitor that's smaller, and so we can measure carbon monoxide actually with very small, light, passive monitors that just, are just the size of like a pen that you can attach to a child's clothing, and it passively measures CO, which is used as a surrogate for PM 2.5. And this is showing those CO monitors in use in the Respire study in Guatemala. The mother has one on and the child has one on. So one thing we learned actually in that study was that it's not enough just to measure once. Repeated measures are extremely important. And these two distributions of the distribution of 48-hour measures versus the distribution of a set of repeated 48-hour measures per child. So the narrower distributions of the child mean, right, that reflects that the individual short-term measures have a wider distribution because it has two sources of variance, the true exposure plus the measurement error. So that's why so the measurement error reduces. The more measures you get per individual, the more you reduce this random measurement error. So this is actually one of the important things to be able to detect an association, because we're usually not looking at, so these measures are very difficult to do, to go out in these field conditions, just get one data point is difficult. So there's no way we could do it all the time and see, did you get pneumonia today because you had high exposure yesterday? That isn't actually feasible with current technology. But so what we aim to do is say, well, do children who typically have high exposure, are they more likely during the first year of life to have a higher incidence of pneumonia? And that's what this analysis in the Respire study looks at. So we took the average of multiple repeated measures of exposure, and we related that to the incidence of pneumonia, adjusting for a large set of potential confounders, and found very strong evidence across multiple different definitions of pneumonia. That's what the different panels are, that there's a strong relationship between exposure and pneumonia. So this adds to the evidence. This was the first study of actual air pollution measurements in a setting like this related to a disease outcome. So a little bit about risk assessment. So now we know, there's different ways to measure exposure, and some are very difficult and some are pretty easy. So that affects how risk assessment is done. But to do risk assessment, you need to decide the disease outcome first, and say how much of that disease outcome is there out there? What's the burden? And then you're gonna look at the contrast of the current exposure versus some counterfactual exposure that presumably would be much lower. And then you use a relative risk function to say what is the attributable burden of pneumonia that's due to household air pollution, right? And so again, this is going to be done right now. We're going to look at the results. Is if you just consider solid fuel use or polluting fuel use, the exposure, versus if you consider PM 2.5, the exposure. And here's the results when the dichotomous. So this is a summary of all of the epidemiology. You see ARI in children is kind of what we've been focusing on. And you can see this in 2020, there's now many more studies than there was during the previous Durrani meta-analysis. And now also we have studies on a whole bunch of other health outcomes, but we'll mostly focus on pediatric ARI. The estimate is somewhat lower than before, 1.39, about 1.4. So maybe a 40% increased risk of ARI associated with household with use of solid fuels. as the exposure. And there's also associations with mortality. And this is what leads us to the estimation of 1.8 million deaths. And so that's one form of risk assessment. And the other one is what's done by the Global Burden of Disease study that's now based in the Institute of Health Metrics and Evaluation. And so a similar list of health outcomes are studied. And for all of those health outcomes, we have what's called the integrated risk curve that's jointly calculated using epidemiological studies of ambient air pollution. So this is a big difference from before. And why would we do that? As I mentioned, the study I just showed with the green plots was the first study ever to look at an exposure response of anything in household air pollution. And there's still actually very few, in most of the diseases that we're interested, don't have any studies where they've actually measured the pollutants and measured the outcome. So we take the small number of studies in these settings and we combine it with a very large epidemiology on ambient air pollution, right? And we kind of account for the levels of air pollution and draw a line through all of those studies. And this is what those look like with the different sources of air pollution. And it's really the pink ones that are point estimates for lower respiratory infections based on PM 2.5. And you can see that the outdoor air pollution or green is much lower exposure, but there's still associations actually at very low levels of pollution. You can also see something here that at very high levels, it's kind of flat. Like you could have, if you have an extremely high exposure, you could cut it in half and expect almost no health benefit according to this curve. That's a really important thing when we try to understand the effects of the interventions. And this is just showing that these same kind of curves have been drawn for other health effects. And they can be really different, where cancer tends to be very linear and some like stroke tend to plateau very quickly. So so I mentioned, so now we have epidemiology, right, but we need exposure assessment. So the other work is taking all the household air pollution exposure assessment studies done around the world and building a model that estimates for different populations what their average PM 2.5 exposure due to household air pollution is. And this is sort of what it looks like globally. These are the distribution of the results based on modeling. And so now those integrated exposure response curves are combined with these actual household air pollution exposures to do this risk assessment. And this comes up with the total number of 2.3 million deaths. And so it's quite similar, 1.8 and 2.3, given all the uncertainty around 2 million deaths is what's estimated from all this evidence. And okay, and you can look at the burden by country again. It's, you can see high burden in Central America and parts of Asia and Africa. So this is looking at the burden by age. Of course, in early life, it's very high. And what's surprising to a lot of people, particularly in adulthood, is that why isn't there a much larger burden in women? Aren't they the ones that are doing all the cooking? It does seem it's still true. Women do almost all the cooking around the world. So why doesn't it translate, and they do, and the model that I showed before, they do have higher exposures, right? But remember, the other piece of risk assessment is the actual burden of that outcome. And so a lot of the outcomes here are things that happen more in men, like cardiovascular disease in these ages. So that explains why the burden is similar. So now, that all seems fine, and why do we need to do research, right? Actually, Kirk made this case, actually wrote this while we were in Guatemala, starting the first trial ever. And what he thought about this, the original paradox, this is not based on the findings, this is based on why do we need to do this? because about half of the people you talk to say you don't need to do studies of that. People who know about air pollution, its toxicology, people who have studied ambient air pollution and know about those concentrations, that it's concerning when you get 20 micrograms per meter cubed of PM 2.5. Why would you be asking about the health effects when it's 200? Of course, it's not going to be good, and we need to do something right away. But the thing is, so as he says in this, he kind of quotes people you talk to, been around the world talking about this issue and going to ministries of health, right? And you say, well, they have evidence of the antibiotics and vaccines that are mostly affordable. There's usually large numbers of randomized controlled trials, not observational studies. So, so there's a reason for that, right? You don't want to just invent a vaccine and stick it in a bunch of people and watch what happens, right? You want to do a very controlled experiment before you give something to a large population. And this is an exposure that's just been with us since, we've been human. And so it's a very different scenario. But how, so there's this need, apparently to provide a similar level of evidence because there's so few resources. And he's making this case that it's really because when you have, it's a paradox, but because if you have larger health problems, why, in a certain setting, would you want more evidence to do something about it? It seems like that's not the case, right? But if your resources are a lot lower and you're, the Ministry of Health isn't used to thinking about the environment, that's a different ministry, right? So where are your RCTs? So that's why Kirk, worked, actually, it took him, about 15 years of applying for R01. So if you ever apply for your first R01, you don't get it. Remember Kirk. So after about 15 years of trying to convince NIH, finally, it was knocking on the door of Gates and all other places, finally got the funding to do Respire, randomized exposure study of pollution indoors and respiratory effects. So this is a trial where in pregnancy or in early life, families were randomized to receive a chimney. So the contrast here is not clean fuel, dirty fuel. It was more thought to be a very practical trial because these are stoves that are out there in the community and that were very desirable, and that development organizations and communities, there was a lot of demand for these. So this is perfect. This is what we should use. We don't want to study gas that nobody can afford, because then we go away and nothing's going to happen, right? So that was the thinking. This was very useful, and it seemed to work compared to other, affordable stoves with chimneys. And so what the outcome was pneumonia. There was a two-part screening process where the first part was a field worker nurse going to the house and looking for any signs and symptoms very broadly. When a child's sick, they're referred to a physician who is blinded. So in trials, like it's very feasible in a vaccine trial, you can blind everybody. The participant, the researchers can be blinded until the end. Here, you can't blind everybody all the time, but you can blind some people some of the time. So the physician didn't know the intervention status and gave the final diagnosis that also included an objective measure of the chest X-ray and oxygen saturation. So this is the exposure contrast. As you can see, there's a large reduction in exposure, about a 50% reduction in exposure during the trial period. In this is based on the CO tubes that I showed in the photo. And here are the findings. So here's the first somewhat paradoxical situation. So the primary outcome, when you do a trial, you have to usually pick one outcome, that unless you want to share the p-value with another one, you just pick one. And so you can see here, there's two models. One is a simple, complete case analysis, and the other one is one that's adjusted for some of the missing outcome data. So it turns out that not all the children who were referred to the physician went to the physician. So therefore, we don't know if they have pneumonia. When we looked at that, it was differential. The children in the intervention group were more likely, probably because we had just given them this nice stove, they were more likely to go when we asked them to go see the physician. So, but still, the confidence interval, even with adjustment, the darker circle is a stronger effect, but still not significant. So for a strict trialist, it didn't work, right? So a lot of us are still kind of believing that this affects health and thinking, well, that's there's some evidence there. But then, and also when you look around at some of the other secondary endpoints, we realize, well, maybe that wasn't actually the best endpoint, because these other ones are actually more severe cases that have a higher risk of mortality, and they are statistically significant. But still, for the trial perspective, primary outcome, not less than 0.05, end of story. It didn't work, right? But I really see, as mixed. The main thing I learned from this, the next trial needed to be a little bit larger. There was just a power issue and get all of the outcomes. So other trials were done, one in Malawi, actually, that found absolutely no evidence of an association, but they hadn't done the pilot work, and actually it turns out that their stove didn't even reduce exposure. So this trial wouldn't really count it as evidence for or against an effect of an intervention that reduces air pollution, because it wasn't an intervention that reduces air pollution. And so then comes the HAPPEN trial, and this is the study that's ongoing. We have some preliminary results to share, and we're still working with this population and proposing additional research. But just briefly, it's a very similar design, but all of the women were recruited before 20 weeks of pregnancy to try to, again, thinking of the timing of the exposure, we were trying to move back a little bit further. In Respire, a lot of people got the intervention around birth. And the intervention was going to be a gas stove, so it's thought maybe we'd get a larger contrast in exposure. If remember that flat point on the curve, maybe in Respire, although we had a pretty good exposure reduction, maybe we were mostly on that flat curve, and that might have been part of the reason why we didn't detect an effect. So many outcomes were studied, but we're focusing really on one of the 4 primaries, which is child pneumonia in the first year of life. But as you can see, there's a lot of other interesting health and biomarker information that we have that still needs to be worked on, a lot of incomplete manuscripts still, and a lot of opportunity for students to be involved. And others. So what does the exposure look like? A slightly larger effect on exposure than Respire at a 62% reduction. But still, maybe that's not enough. We don't know. But it also, if you look at the distribution of the exposures around those point estimates, it just reminds you, like, don't we want to somehow use all that information? It's not really just 2 groups, right? Of course, those are not randomized. Only stove is randomized, right, to get the gas stove. And the intervention, I should have mentioned, includes getting the stove. The fuel was free for the whole study, and there was a lot of behavior change, messaging, and techniques to try to encourage gas stove use, which was overall very successful. And almost the vast majority of people used the gas almost all the time. And so these were the findings, even more paradoxical, not even a suggestion of an effect. And this is a larger study in 4 countries. I didn't mention, but it's India, Rwanda, Peru, and Guatemala. And this is, we have the primary outcome. And even if you look at more severe cases, there's still no evidence of an effect. So it's really kind of troubling for some of us that this is the case. And this is some sub-analysis. There's, you could look at it forever, but nothing really pops up as being even suggestive. It's just smaller sample sizes, and it's bouncing around in both directions. And these are all the people, the institutions that were involved in HAPPN. Actually, UGA was involved before I came here. Dr. Luke Nair was the PI of the study here at UGA. So what are some of the explanations? You know, we think there's a really large public health problem, but we can't do an intervention and show that it works. So one thing is thinking about causal inference a little more carefully. So identifying and interpreting the effect of a treatment on outcome requires, or intervention, requires knowledge about how to intervene, right? And this is a really important thing in anything that's behavioral or environmental, right? So this is something that we want to try to take into account. And so, you know, one thing in terms of the interventions, there's obviously the question of, you know, maybe a 60% reduction in exposure is not enough. Maybe being 20 weeks pregnant when it starts to occur is not early enough. So those are two questions. The other things, though, are how did we reduce household air pollution, right? How does it happen in real life when we do observational studies, right? Well, people decide, they have the resource and they decide to go and switch to a clean fuel, right? But in a trial, you want to make sure they do that, but they don't have the money to do that. So you have to pay for their stove and their fuel. So people who used to spend their time collecting wood or purchasing wood no longer need to do that. So that can have effects that we don't understand, right? And it could affect people's physical activity, their diet, their stress, and their sleep, because actually in very poor communities, you know, the amount of household expenditure on getting fuel for cooking is actually a large proportion of people's income. So taking that away can obviously have other effects besides the difference in air pollution. So this is a directed acyclic graph that kind of gets at that, where we're really interested in the effects of E, at least that's what we think, but to change that, we have to change the stove people use. And in our study, the intervention was a little broader. It affected other things besides the stove. And all of this can have, say, behavioral effects on behavior. And any of those may influence some disease outcomes. So those are the kind of questions that I think we need to answer. Is there something about the way that we are intervening or when we're intervening that is explaining these paradoxical effects? Other things are just the challenging. You'd think that something that was the #1 killer of children in the world and that we all know what it is, you think it would be kind of obvious when you have it. It turns out it's not. When you ask physicians to classify pneumonia, they don't agree very well, even with the X-ray. That you're lucky to get a kappa statistic of 0.8 if you are very good. And so there's misclassification kind of randomly, and there's also perhaps other kinds of biases in case ascertainment. In addition to ascertaining the cases, maybe we should think about this outcome more specifically. I'm never sure whether to put this one under the category, is this about the population, because it's related to a potential component cause that a population may have more or less of, but it's also, which are certain pathogens, but it's also related to maybe defining the outcome more specifically. And so here is what we're looking at. One of the interesting results from Respire that unfortunately the team in HAPPN didn't really follow up on was this difference in the exposure response relationship if a child was RSV positive or negative. So being RSV negative suggests it's very likely to be a bacterial pneumonia, since RSV is the major cause of viral pneumonia in young children. So these two curves, right, where there's a very strong relationship with RSV negative and air pollution, but not RSV positive pneumonia, and air pollution is something that needs to be investigated as well. So why would that explain the paradox? Because the observational studies were mostly done before we introduced pneumococcal and Haemophilus vaccines. And most of the trials have been done after we introduced those vaccines. So this is, again, another really important. So maybe studies need to differentiate these outcomes in the future. Of course, ascertaining cases in these settings is not easy. I mentioned that pneumonia is complicated to diagnose. This is a flow diagram. And just like in Respire, I mentioned missing cases. All these red circles are places in the branching logic to determine whether you're a case at the end of, in that branch, we're missing the information to move forward, or it's partially complete. And some of these affect the primary outcome, and some of these only affect secondary outcomes. And these are just the missing data that we know of. In HAPPEN, let me just maybe compare the two studies. In Respire, we did active surveillance. We visited the households every week. In HAPPEN, we waited in the health services, assuming that if they had pneumonia, they will seek care. I was not in favor of this decision. It was a change in our protocol. It wasn't what we proposed to NIH, and it was what was encouraged by external advisors that were brought in. So anyways, thank you to Laura, who's here, who made this figure. But complete ascertainment of the outcome is important, particularly in the setting of an unblinded field trial, where everybody knows whether you gave them something or not, and then you're trying to get information. So really important. So the paradoxes is starting to see, oh, there's a list of things now that might explain why it's so difficult. So here's the team in Guatemala, and so talk just a few minutes about the future directions. I think we're going to continue to follow this cohort and learn from what happened in this intervention, but I think we need new observational studies, because that would possibly explain part of the paradox. If we do observational studies now, really good ones, and we don't find the association, then we'll say, okay, well, maybe it went away. Maybe it was because there was a lot of pneumococcal pneumonia and now there's not very much. But also, I think it's definitely tempting, as wrong as we might be, wrong-headed and stubborn, to try to do another trial. I really think that we haven't done the best we can, and it's possible to do a better one. So the first thing we need to do, I showed you results from the intention to treat analysis of HAPPEN that are preliminary results that are not published yet. But the next step, which we haven't done, and we're determining the statistical analysis plan now, because this is so complicated. There are a few pending questions, but to do this, we want to think a lot about how we calculate the exposure. We want to think a lot about how we adjust for confounders, and also with the bias that I showed in the causal graph. We need to think about, does it make sense to actually think of this intervention that was randomized, think of it as a confounder? Now, that's not what people usually do, but it might be appropriate in this setting. So it's just a question of whether it's the primary analysis or it's a secondary analysis to do such an adjustment. And also looking at whether there's differential ascertainment of cases with respect to the intervention, whether that could have caused bias. So we are starting actually under a new funding, a new project, the Guatemala Respiratory study that is just in one of the 4 countries, just Guatemala, and led by UGA, and is asking whether there are longer term effects of this early life intervention. We're going to look at lung function and respiratory disease. This is the title, and a summary of our aims. And the aims also involve looking at biological mechanisms using DNA methylation. So this is really exciting. We just had a meeting with our team from Guatemala here in Georgia recently, and we hope to start data collection in December. Here is the plan of the data collection. You can see the data we already have and the data we plan to collect to get an idea of what we've already done, a pilot of lung function at 3 years of age. And this manuscript by Peel asked, whether RCTs are necessary. I think I went over a lot of the limitations and and even questioning myself whether my desire to do another one is the best thing. Maybe somebody could convince me otherwise, save me a lot of time. But I think a prospective cohort study would be valuable. And if we did an improved RCT, what would we need to think about? I think, what is the contrast? And I think the intervention side could be electric induction stoves that are more practical. And you don't have to, once you set it up, you don't have to give a lot of attention to the family, like coming by and always giving them gas. I think that relationship with a research project can lead to bias. Also, the control, whatever attention we do give to the intervention, the attention to be similar. And if we give them something free, we should give the other group something free that would try to control in a way, again, for these other pathways that might lead to pneumonia, and try to get it to a point where it represents what might happen, what the contrast might be in real life. And a little about exposure assessment. And I think we have 1 minute for discussion. That's not too good, but I'm available to stay if people still have questions after that minute's over.
Thanks, John, for that very comprehensive run through of all your excellent work that you've done over the many, many years. It's definitely informative and stimulating. Many new ideas and gaps that could still be researched, addressed, and interventions, most importantly, for this global health problem. Anyone has a burning question that would like to use the 1 minute? If not, I was wanting to ask John, you talked about this just last piece where you talked about the electrical, you said the electric intervention, induction stoves. Is that something that you have seen other people use, or is it sort of one of your creative ideas of what would make this more effective?
Yes, yeah, they're more, it seems like they're more popular actually in low-income countries. They save you a lot of money on electricity. If you need a new stove, definitely think about it. But it seems like they're not that available in the US.
I haven't myself. That's why I haven't
seen many, but I think you'll use about 1/3 of the electricity, is what they claim. And yeah, there are national programs. For example, in Ecuador, they have a large national program that has distributed a lot of induction stoves. And there are examples of interventions in low-income communities. We haven't tried it ourselves in Guatemala, but the Ministry of Energy and Mines in Guatemala, for example, has some programs going on that it's more in peri-urban areas where we work in a more rural area. But it's one of the things that I think, regardless of whether we do epidemiology, I think just maybe with faith in the epidemiology that we do have outside of the trials and our knowledge of air pollution, I think that it's really worthwhile trying to get these stoves into more communities and learn more about the environmental, economic, and practical aspects of using them.
Yeah, that would be definitely very helpful for the large scale adoption in the future, I would imagine. Any other comments, quick questions before we wrap it up? Hearing none, I will just ask all of us to thank Dr. McCracken. You can use an emoji to clap or just drop something in the chat. But yeah, definitely thank you so much for this excellent presentation, Dr. McCracken. I appreciate it. I see a lot of emojis coming up with hand claps, so thank you.
Someday I'll learn to leave time for questions, but again, I can stay if anybody
Yeah.
has a
And
question. Yeah.
and we can always share the email if students wanted to reach out to you. I see mostly we have our students who are on the seminar. So yeah, thank you.
Yeah, next, I
Again.
guess I'll maybe just mention, if this was interesting, the course on environmental epidemiology will be offered next fall.
Okay. Very good.
Learn more about this and other environmental health issues.
All right. Are you taking any students who are interested in research for a period? Since we have a lot of students here, that might be an interesting question. They're always looking for opportunities to immerse.
Yeah, I think we have a lot of opportunities, a lot of data sets, and yeah, we'd be really happy to collaborate. I think it's a really good opportunity. Happen as a very large network. As you can see, multiple universities around the world and in different settings, and I think it's a great resource. I hope we can, at UGA really tap into that as much as possible.
Fantastic. All right. Thanks, everyone. And we hope to see you again in the next series of our seminars for October, which will be October the 26th. All right. Take care. Bye, everyone.
Bye.